investigator at the Center for Injury Research and Policy and is at the Wabigow Wexner Research Institute at Nationwide Children's Hospital, and also is a tenured professor of pediatrics and epidemiology at The Ohio State University. Dr. Yang's primary research interest is injury prevention with an emphasis on injuries to children and adolescents. Much of her current research focuses on the trajectory of recovery from sports-related mild traumatic brain injuries among children, and also parental engagement on teen driving safety. She is, Dr. Yang grew up in China and received her MPH in Applied Health Sciences at Indiana University Bloomington, and her PhD in Health Behavior and Health Education with a minor in Biostatistics at UNC Chapel Hill. And today she's going to discuss physical and cognitive activity following pediatric concussion. And with that, I'll hand it over to Dr. Yang.
Okay, thank you so much, Talia, for the introduction. And I really appreciate the opportunity to present here. I also feel your department is very close to me because first, your former colleague, Dr. Comstock, was working at a Nationwide Children's Hospital. I just told Talia I actually was her replacement. I'm sitting in her office today presenting this work. I continue to collaborate with her. And I also, Dr. Carol Runyon, who was my dissertation committee member, also mentor at UNC, and she continues to be my serve as my career mentor, and Dr. Ashley Brooke Russell, and have been discuss about the potential collaboration on the teen driving safety project. So I really appreciate the opportunity to share my research with you. And today I'm going to just cover three parts. First is discuss a little bit about the background of this line research. Second is to tell you about the REACT study, specifically discuss two papers we published based on the REACT study. And lastly, I will discuss about the future direction in this line of research. So concussion is a form of a TBI that also significant public health problem that can have adverse effect on not only physical, but also cognitive, emotional, and also sleep health. Many of you probably have watched this movie Concussion, learn about some basic things about concussion. And concussion also have many definitions, and currently there is no good diagnosis tools for the concussion. So for this study, I'm going to use commonly used definition about the concussion, which defines concussion as a type of a traumatic brain injury induced by a direct or indirect blow to the head, neck, face, or other body part that result force to the brain. Very important that concussion not only can result from direct impact to the head, but also can be impact on the other body parts that transfer that force to the head. So we say this force like yogurt in the egg, when you're shaking back and forth, can lead to brain injury. The concussion is functional injury, not a structure injury. So that CT scan or MRI can be normal, and most concussion will be recovery without any impact. But concussion also very unique. Each individual, when they have a concussion, they can experience different symptoms, have a different clinical presentation, and also have a different recovery trajectories. Not all concussion will result in loss of consciousness. Only 10% of a concussion will lead to that. So that make the challenging because there is no, because the injury in the brain does not have outward blood, and people can not see when you look at concussed patient feel they are normal, actually they are not. And the patient also can experience a range of symptoms that varied greatly in quantity, severity, and the duration from individual to individual. And they may experience symptom over first several hours post-injury, or they did not have anything until days after injury. Here just list some examples of symptoms of post-concussion symptoms we call, because symptom is byproduct of injury. In the research, there is post-concussion symptom scale that including 22 symptoms. So depending on which part of a brain injured, that may associate with different symptoms. Some delayed symptom could also due to coping of the injury rather than injury itself, such as anxiety or sadness because they cannot do activity, leading that feeling, not necessarily direct result from injury. So why we study pediatric concussion? Because first, a high number of concussion is observed in children, particularly when they play sports. So the children and adolescents aged 5 to 24 years is among highest risk group for the concussion. Each year, about 1.1 to 1.9 million of sports and the recreational injury that a concussion is occur in the children 18 or younger. This is actually the study conducted by Don Comstock. Because the high incidence leading to that group as significant risk. The other let me see. Then when we break down by sports and break down by the sex, we also see the high incident that is occur in the sports, followed by girls soccer and the wrestling. But when we compare the comparable sports such as the basketball boys and the girls, and soccer boys and the girls, and the baseball and softball, we see girls have a consistent high concussion rate compared to boys. So the other reason why we study pediatric concussion is because concussion in children and adolescent particular concern because their brain is still in development. The frontal lobe region does not reach its full maturity until they are mid-20th. So if damage to the brain that at any development continuum can impact on their executive function that including judgment, problem solving, and mental flexibility. The difficult part is because the injury that cannot see. So sometimes people think this is just part of a development that actually they go to the different direction compared their normal development. Another important thing need to note here is the brain injury in this period can lead to increased risk for negative long-term neurobiological and behavior consequences. The study showed the effect of a concussion on the cognitive ability can still measured 30 years later. So it is important to get when concussion occur, get treated, healed, so it does not have long-term impact. Traditional approach to manage pediatric concussion emphasize need for rest. So traditional, basically physical and cognitive rest until symptom-free. The rationale for this is because trying to avoid absorption of the brain during this vulnerable and critical period. Then also rationale for this is allow body sense the energy, body rest so can send the energy to brain for the recovery. However, the body of evidence challenging this approach because first is have kids to rest, don't do anything that is not practical, how you can stop thinking the brain activity. Second is may not be necessary. So current recommendation is say that is just say the kids need to be returned to gradual and progressive activity after they are 24 to 48 hours rest. However, when is the best time, how that rest, amount of a rest and duration of rest and time start rest will affect outcomes still unknown. And we also from the literature, we know engage in high level of activity too soon post-injury can increase symptom duration and lead more neurocognitive function impairment. On the other hand, complete rest, especially prolonged rest, can be unnecessary or impractical, does not offer any additional benefit. And the recent research also show early introduction of a symptom-limited physical activity is safe and can accelerate the recovery process. So, however, still the body of literature still have not have a definite when that activity can start, how long the rest need to be. And also this can be also the diagnosis itself can be challenging because most diagnosis is based on symptom management, also is based on managing the symptom. So we're trying to conduct a study, help contribute to the literature on this end. The study is called a REACT study funded by NIH as R21 with the focus here, the two aims is measure the level of physical and cognitive rest. It is inverse of activity following sports-related concussions, and also describe how this level of physical activity and cognitive activity associate with the recovery outcomes. So our study population is youth age 11 to 17 years old with physician confirmed concussion. And we recruit our study participants from local middle and high schools, emergency department, and concussion clinics at the Nationwide Children's Hospital. We enrolled youth along with one of their parent or guardian within 72 hours of injury and follow them until their symptom resolve or they are 45 days post-injury, whichever occur first. So we prospectively follow with them, and with a repeated measure, the participant complete 3 assessments and also monitor their daily symptoms. The first assessment is within 72 hours of injury. That was very challenging. I will discuss that later, but we want to get to that acute period. Then we follow their second assessment 1 week after their first assessment. Then the last assessment is at symptom resolution or whenever they are recovering. So we also monitor their daily physical and activity symptoms. The challenging how we monitor that cognitive activity, rest and that is, I'm going to tell you a little bit. So we use the autograph. This is probably people familiar with that is and a heart rate monitor to do the monitor the physical activity, and we use a narrative clip that is a mimic camera. I will show you the picture. Then we also do the daily self-report. So here is autograph that is just research grade of a Fitbit that will monitor the step count and also the mat minutes. And we have them with the heart rate monitor to monitor the physical activity. We have them wear 7 days post-injury. Then we also measure the cognitive rest because we are have a difficult time say how we can measure their cognitive rest or activity. So we talked to the people. Finally, we use this mimic camera. Actually, this is the camera. Probably you can see that is very small camera that take a picture every 30 seconds that allow us to document the activity. And as you see, this is they are in the classroom, homework, video game, and the texting if they do. The reason we decided to use this camera is basically measure what they see. We feel all the cognitive activity required they use their eyes. So basically, instead of what they do, we basically record what they do while they are using their eyes. To help stabilize that camera, we also use a 3D printer print this narrative wedge. So that will be, first is the angle is fixed. Second is capture that normal visual field. So whatever their eyes using, we capture their activity. So then, because both cognitive the autograph and narrative clip have the time stamp, so we can match their time with their physical activity and the cognitive activity when we collect data. So this is just picture like showing the concept. Then when we collected data, we actually utilize some computer vision to do the segmentation and also classification. So the activity, if based on the color and the object, so if the color was the camera color showing the background is red or black, because if it does not have anything, then the computer, we training the computer to recognize those, or they have a TV within the background, we training that. Then that method is called the CNN model training. Then when that following the training, they basically can distinguish which one to separate them. So, but the challenging is because the activity the kids can do, the cognitive activity we measure, they can do texting while they are interact with a friend. So sometimes that is not unique. So we utilize this, but we also have the coder to code the activity. So we utilize based on the color screen that can segment the data, which can save the time, but we still need to go into recording those activities. So that it just helps a lot to go through, but also we not only coded the activity, but we also based on the frame every 30 seconds, we know the duration of the activity. So based on that, we establish the coding and code the data. So here's the some result. First is we have 83 participants in our study that 65% are males, 35 are females. This is similar to what is being reported in the literature. The age from 11 to 17, about half of those are 15 to 17. And we also have kids who injured in the different sports, and about 1/3 were injured in football. Here are some demographic and the injury characteristics of the participants. About 72% are white and injured in the almost 85 in sports, and about 1/3 have history of a prior concussion, and we about 84% was resolved within 4 weeks, but we have 8% past the 45 days, and we were able to enroll them average 1.2 days, especially from ED we get to them. Their symptom score at injury is about 43, and they have 14 symptoms. So now I'm going to just tell you a little bit about the first paper, that finding from the first paper, and that focus on assess first week of physical activity and the cognitive activity recorded by the objective measure, then how that relate to the outcome of a recovery. So the outcome of this paper is focused on number of days from injury to symptom resolve, or to 45 days. The exposure variable are two. First is the level of physical activity. During the first week post-injury, we measured it as a step count and also mat minutes that by autograph. The second exposure variable is cognitive activity across the first week post-injury. We measured it by weighted cognitive activity that by collected by narrative clip and also self-reported the school time. The reason we did a weighted activity is because when we in the data collection, the school does not allow the kids wear the autograph in the narrative clip in the school, because the camera is outward, so we're recording other kids. So we, based on their wearing time, and we imputed, assume if they are in the school time, also where what the minutes will be. Then we use the Cox proportion hazard model to estimate the relationship. Here's some findings. First, we see during the first week post-injury, the average daily step increased. So from 7,000 per day to about almost 11,000 steps per day on the day 7. And we also see the daily symptom reduced. That is at injury, and the enrollment that is about 30, and also on the day 7 about 14. So this is the scale for the post-concussion symptoms, this scale for the steps. So we see the inverse relationship, and a similar daily physical activity mat minutes also increase over the first week. And however, when we look at the activity intensity, we find majority, half of activity, daily activity is light activity. So we see the pattern does not change. The intensity does not change. So most is light activity, moderate and vigorous is vigorous almost 0. Moderate is less than 1 hour. So the first week, actually, the activity level is quite low. So when we look at the cognitive activity, we see the cognitive activity during the first week. Also, most is a low level cognitive activity. This low level of activity is kind of watch TV and listen to the music. Moderate is they do some surfing the internet. The high intensity activity where they do the homework, they are driving, play the computer games. So that is, we see majority kids still engage the low intensity activity, you see that low is a decrease, the high is increase as they progressive through the injury. And the school time increase, you see the first day is about 60 minutes on average, and that until almost less than 250. So all these kids still have not fully returned to school yet during the first week. And I would say that data collection is 2017 to 2018. That is very different if we see 2019 and 2020 because the change of the recommendation. So when we look at the relationship, we find the increased daily steps was associated with increased likelihood of symptom reduction. Basically, this is unadjusted hazard ratio, but that was not significant when we adjusted other variable, particularly adjust the symptom score at injury. And we also find the greater school attendance was associated with early symptom resolution. So this is our the first study. However, this study have some limitation. First, sample is relatively small, so the results should be considered preliminary. The reported level of cognitive activity could not capture participant actually mental engagement in each activity. We only know what they did. We don't know how engaged they are based on the recorded imaging. The narrative clip wearing time was relatively low, that about 400 minutes on average across the duration each day. So that because we are instructed them not to wear narrative to school due to the privacy concern. When we impute it, we have assumption that is the same when they're wear, not wear, which may not be true, so could be biased. And the result for this study may not be generalizable to other population. So this is a limitation. And because of this study, we also find that for this study, we see that inverse relationship why early physical activity may be associated with fewer symptoms, and a fewer symptom may also predict increased activity. So we kind of don't know which is the chicken, which is the egg, because if they feel better, symptom low, they engage more, or because they engage more, they reduce the symptoms. So we decided to conduct the second study focused on bidirectional association between daily physical activity and the post-concussion symptom among youth. So we coded group the daily steps and the post-concussion symptom during the first week in 3 waves. So wave 1 is post days 1 to 3 post-injury. Wave 2 is days 4 to 5 post-injury, and wave 3 is days 6 to 7 post-injury. Then we examine the bidirection association between daily steps and the post-concussion symptom. Use 2 modeling. One is using traditional cross-legged panel model. Then the second one is random intercept cross-legged panel model. The model, the random intersect, the new model take not only adjust within individual difference, but also between individual difference. So that counted both within and between. So we assessed the 0 correlation among 3 waves, find that was correlated as we showed the picture in the graph in the first study, that is increased activity was associated with the decreased the symptoms. then we look at the bidirectional association. Here is basically we look at the regression, like step one, like wave one, wave two, wave three, wave one, wave two, wave three steps and symptoms. We also look at the cross that each way. So the solid line to indicate that is significant result. The dashed line indicate is not a significant result. So as we, from this, we show positive autoregression association were observed between the from the step count from wave one, wave two, wave three, and also post-concussion symptoms, wave one, wave two, wave three. However, only one cross-lagged association was significant, that is wave one PCS score and associate with steps wave two at steps that is negative correlate, or other cross-lag is no association showing here. Then we also use the random intercept cross-lag model, that here we're taking care of between person here. So we see this between person is significant, but within person, all the association within person, cross-lag, or even the correlation autoregression is no longer significant. So only between person effect was shown, but all other cross-lag path was no longer significant. This means when accounting for between person difference, the within person correlation was no longer significant. In other words, the within person association observed in tradition model may include in both between and the within person association. So this study also have some limitation. First is a small sample size. We did not adjust any individual difference because the sample size, and the participant may opt out wearing device, or their activity may not be recorded properly. We just based on what's being recorded. And also participants may with great PCS may limit their physical activity, perhaps because of physician recommendation, because this is an observational study. All these kids receive a treatment at NCH. So what their activity can be physician recommendation, but we did not adjust in our analysis. Based on these findings, we think the future direction very important. We need to have a better tools to objectively measure both physical and cognitive activity post-concussion. We find self-report that based on the literature and based on our finding is not correlate with objective recorded quite well. So we need to have a better tool, particularly how we measure cognitive activity. It is challenging, and this is the brain injury, cognitive rest, and the cognitive active play the significant role. Second is to assess how the activity affected the recovery outcomes, such as post-concussion symptom or other outcome, is very important to conduct a randomized trial, so we can have a control group and prescribe the activity to see how that change. Because right now everything is self-directed, self-paced without controlled. So in that way, it is based on how the kids want to do, so that may not be as accurate as if we do the controlled trial. So future study need to assess a better relationship, use a control trial. And most important, since the concussion is very different from individual to individual, we need, based on these findings or clinical trial, that can develop a individual tailored recommendation. So engage youth early in activity that promote their optimal recovery. So this is, I want to acknowledge my collaborators and also research team member and all others who engage in this research. Without them, we cannot achieve what we have achieved, particularly our study participants. They are participated in our study. So I want to thank you for your attention. I'm happy to answer any questions you may have, and I'm open to the questions. So I can stop share my screen. Is that okay? So in that way, okay.
Yeah,
Thank you
Dr.
so
Yang, for that
much.
interesting talk. Are there any questions?
I have a question. Hi, Dr. Yang. Thank you for that talk. My name is David Higgins. I'm a pediatrician first by training and now in a MPH epi program here and in the preventive medicine residency. I'm curious with the first study, you had the camera. I don't remember what the narrative clip, right?
Yeah.
And I know that you looked at the different cognitive levels of activity. Did you try to look at how much time they spent looking at screens? You know, we have this, you know, I don't know how good the research is on this, but as pediatricians, there's always this emphasis that kids not rest by going home and just staring at a screen all day, right? Were you able to see that? Were you able to tease out how often they were looking at any type of a screen and whether there was any correlation there with symptoms?
This is a very good question. Actually, we coded their activity based on the Boston children's that beyond Meehan, they have the level of activity. So we coded this activity, say the interaction with each other, and they do the homework, and they watch TV, and they look at the cell phone. All this, but we did not specify code. We actually can do it based on our coding. We can summarize the screen time. I think you just give us another research topic to study, so we can actually look in their total screen time, and that to correlate with their outcome. But for the first study we just classify the activity they have. Now, by the way, that is a study is published this year at Journal of Head Trauma and Rehabilitation. I'm happy to send, but if you're interested, happy to collaborate with you. We can look at the screen time and to calculate the time, look at the outcome, but we did not look at that variable. But
yeah.
We are able to look at that variable.
Right. I think your study design is great and unique in that you have the ability with the photo to actually see if they're looking at a screen, because it is definitely something that is as pediatricians are spreading out there, this idea that there's something intrinsically about looking at a screen that may prolong symptoms. But I don't think we're saying that based on really good research. So it'd be interesting to look at. Yeah. Thank
sure.
you.
So if you can send me email and you're interested in looking in collaboration, and I'm happy to work with you on that.
Great. Thank you.
Mm-hmm. Any other questions? Can ask any question related to the methods we did. We were struggling when we trying to. We know the kids, they are move around. We cannot just put the camera at home, so that the kids, we give them incentive for how many each day they wear the camera. It is like, so it is kind of have to put their front like forehead. So but the kids we were able to, we captured their time and were wearing off to school. Other questions or comments?
Hi, this is Tracy Beckelman.
Hi, how are you?
Good. Thank you for that very interesting talk. That actually it's not my area of expertise. I was very interested to read what seemed like an expansive definition of concussion. I didn't realize that indirect hits are part of the definition. So I measure children's diets using image-based photography, and we've had a lot of challenges doing that in the school setting. And I was wondering, with the wearable that you used, if that's maybe why you didn't use it during the school hours, the confidentiality issues or the permission issues, and what are some of the barriers to using that kind of technology during the school day?
Okay, this is very good question. We actually, when we received the funding, we cannot start the study because the NCH was so worried that camera can be lost, picked by someone. We actually have by computer for each kids, so they have autograph narrative clip computer for them, download the data every day because that is the requirement, so the data can be sent to school. Because as soon as they the narrative plug into the computer, the data uploaded, the data will be in the computer, not in that camera anymore. So that designed, but it is challenging. The school felt originally we said, can we have them wear the hat, put the camera on the hat instead of you put the front? The school said no, because the first, school does not allow wear the hat. Second is they feel this is outward, so that can be recorded to other kids. So we actually advise all the kids, when you are recorded, to tell the people recorded, if they are not comfortable, you need to take that away. So we don't know, we still are looking for other potential, the ones that can be right now. I think the new technology can put something as a glassware, they can put something there, but we know that is also the battery issue, like how long the battery can be lost. So that is also the cost, but it is a constant battle that we hope can be solved, because that is, as Dr. Hingus, right? Hingus.
Yeah, Higgins.
Yeah, mentioned that screen time, because if we can record it, that will be so. But I hear what you say. It is challenging to use the technology to do the study, but this is just the first step.
Yeah, thank you. That was really helpful.
Other thoughts and the questions, or that I'm happy to share with whatever in this. That is always, I think the currently also diagnosis is also very challenging, because physician usually based on the diagnose, that based on the symptom, and that symptom is subjectively reported. So we are right now the study trying to see if there is any biomarker that can be determine the diagnosis or prognosis of a concussion. So, but this is because the time constraint, I just reported a little bit here that we have done. But it is a great area to study, particularly among children. There is so many unknowns.
Ginger, did I understand you to say that you were also communicating with parents? And I'm wondering what kinds of things you're learning from parents or expect to learn from parents.
This is very good question. Parents are part of the study. We also actually did the interview with parents right now. The paper was accepted, but have not been published yet. Is their experience with their kids' recovery during the concussion. because state law require all the concussed children, if the concussion is suspected, they have to remove from play. They cannot return to play until they get clearance from the doctor. I actually collaborate with Don Comstock, looking the concussion law, how that impacted the concussion. But there is no, some states have the law that return to learn that, but not all crossed. There is also no good evidence support how can help kids speed the return to learn. Because that engage not only the teacher, but the nurse or other involvement parents too. So we find that return to learn is challenging. The parents told us the decision regarding return to learn is decided by kids sometimes, because parents don't know, say, are you okay to return? Kids want to return, and the kids' parents don't have evidence tell them you don't, and you go. So sometimes it is depending on the kids. They return to learn or go back to school. Then when they go back to school, their symptom increase because the activity increase. So they, based on their errors in the trial, decided when you can go. If your symptom increase, then you kind of not go. So that actually that line of research is right now is needed, because that how much they can tolerate when they can go, because for the physical activity, because there is cap, they cannot go. They also have a progressive return to play. So they start light activity, they go back by the school athletic trainer or someone help them. But the return learn is just parents really need the guidance, and the teachers also need to be supportive, because the teachers sometimes don't understand the concussion, so they think kids is kind of lazy, does not want to do the work. They just did because the kids look fine. You don't have anything. You can do the work, but that is a we find the parents told us that is challenging how they managing, and they are first concussion on this age, so they don't know how to deal with.
I had a question if you for you from one of your earlier slides, and you showed a plot of, I think, sports related injuries by gender, and showed that it was actually higher among girls or females compared to males. Can you go into a little bit of detail as to why that is?
Okay, this is very good question. We still in research identify why the female actually have a high injury rate, and particularly same sports. Of course, football always very high, contact sports high. So possible reason is, first is a concussion is a reported concussion. So the female more likely to report. That can be one of the reason. Second is right now the research finds is the girls, the way they play may be also different. Certain sports, say lacrosse, the girls does not require how much of the boys required. But the soccer, that is the same. But the reason is because the tolerance of impact, girls may have less tolerant impact on when they have impact either on their head or on their body. So that they more like, because the injury is about whether you can tolerate that force. If they cannot, that lead to injury. Then also some study also find that can be the hormone level, that sometimes the symptom, depending on they are in their cycle, that symptom can be also their hormone change that can be triggered that symptom even more, because that can be. But the style of a play, also the ability, physical ability, the girl, even the say the running the same speed, the girl already make more effort to compare the boy because their body structure. So that is a couple of not only the report, but also biologically, girls may also have more the risk of injury. Soccer injury itself, not just concussion, also female soccer injury is more than the boys soccer injuries.
Hello, hey, Ginger. This
Hi.
is Jean.
Hi, how are you?
Hi, thank you. Great talk, and so nice to learn this very detailed design and the findings from your R21. And I know you work very hard and grow this area into 3 R01. That's not easy. Can you share with us how you, build upon your work to grow this area? And also for your sample, you have age range from 11 to 17. For this small study, you may not able to study, the younger kids 11 to 13, 14, and 15 to 17, how they are different, right? So this is another age question, age effect. Thank you.
Okay, thank you so much for the question. So I first address your question related to the age. Actually, I really want to do, we are doing the pilot study is younger than 11 because the younger age, they are neuroplasticity would be very different. Their response to concussion also very different. And then the early adolescent and the later adolescent can be also very different. We are not able to adjust the age in our study, but that is a good question. And also the severity probably reflects some in the age, because when they are older, they engage more the activity competition level probably more, so their injury symptom score and the injury more severe, so their symptom score probably higher. So somewhat consider will reflect some, but our study was not to be able to adjust future study. Need to be particularly looking younger age. And also the mechanism of injury for our study 11 to 17, this is a sports related, or the 5 or older more sports related. But the younger age, particularly under 5, most injury is not sports related. We did the study compare the younger age, their mechanism of injury is not sports related, and they are fall related injuries, so their severity is very different. For the older adolescent 15 to 17, they are injured is because they are driving, could be in crash, so they have a more severe TBI that can be may not be included in this study. So that age does reflect some development, but also reflect a mechanism of injury. But your question is very good, that do need into consideration. Then related to R1, I feel like I was very lucky. We are still, we got this R21. We proposed the R01. We were scored, but it was not funded based on this line research. So we are still writing this. But the other R1 is related to teen driving safety. That is, I hope that Ashley actually asked me to talk about teen driving because that is what her area. I hope in the future I can come back and tell you about that study, but if you have time, I can just tell you a couple of minutes about the study about the teen driving study. The first study is we look at the parent engaged improve teen driving safety among the teen drivers who received the citation seen in the court. So those are the teen drivers who already started driving independent and unsupervised. And we also know this first 6 months have a highest risk to be injured, to engage the crash. So our study is a focus on user technology that is in-vehicle device that insurance used to improve their customer. We put in their car to give them direct feedback when they are speeding or turn too hard. Then we also in another group, it is a randomized trial, 3 group, first group control, second group is the feedback, third group is the feedback plus parent engagement. So we are training parents. That is building on the project I worked at the University of Iowa. So we training parents use a motivational interview technology to talk to their team, because this age is a very difficult age. So we training parents to talk to their teams based on the objective data, use the motivational interview in technique to improve the driving safety. So that is the first study. Second study, we based on that study, develop the study, translate to engage rural families. And we also deliver the intervention not through the expert, rather than training the parents to be peers, so they can deliver the intervention who also through the same experience, so they can deliver, and we assess the cost effectiveness of delivered by expert or delivered by the peers. The last study is multi-site and multiple PI collaborate with UAB, looking how concussion affect driving. So we, among the team drivers, we recruited the team driver, also acute, have them driving on the driving simulator, high fidelity driving simulator, to see how that driving affected them. We compare their driving with healthy controls. So that is the TBI study, but all focus on the team driving. Hopefully I have opportunity to share with you in the future. And I felt that is also very interesting study, and hopefully that can, particularly the driving after TBI, right now is no policy. The kids get injured, cannot go back to play, may not go back to school, but we don't know the evidence when they can return to drive. And the drive require that decision making, and also the reaction time in such short time compared the one that other activity.
Thank you. Great. Yeah.
Thank you.
Yeah, and thank you everybody for attending and for that great discussion. And again, to Dr. Yang for her great presentation. And with that, I think we'll close it out for the day. So thanks everybody.
Okay, thank you so much. Nice meeting you all, and really appreciate the opportunity. And